31, a 5-year-old boy undergoes CT of the brain for investigation of headaches, vomiting, and ataxia. This demonstrates a well-defined, multilobulated, isodense mass within the fourth ventricle containing areas of punctate calcification. The mass is seen to extend out of the foramina of Luschka into the cerebellopontine angles. There is associated hydrocephalus. What is the most likely diagnosis? A. Metastasis. B. Hemangioblastoma. C. Juvenile pilocytic astrocytoma. D. Medulloblastoma. E. Ependymoma. 32, an 18-month-old causing orbital fat stranding. Dehnert, 2007, 344. 31, E. Ependymomas most commonly arise in the floor of the fourth ventricle and are usually isodense. They have a greater incidence of calcification than other posterior fossa pediatric tumors. It is typically punctate and seen in 40–50% of cases. A characteristic feature of ependymomas is their propensity to extend through and widen the foramina of Luschka and Magendie. Juvenile pilocytic astrocytomas are the commonest pediatric infratentorial neoplasms and typically occur in the cerebellar hemispheres. They appear cystic with an enhancing neural nodule. Medulloblastomas tend to be homogeneous hyperdense lesions located in the vermis, and the presence of calcification is uncommon. Metastases are the commonest infratentorial tumor to occur in adults but are uncommon in children. Hemangioblastomas usually occur in young adults and are classically cystic masses with a solid neural nodule. Grossman and 18-month-old toddler presents with progressive gait disturbance, motor developmental delay and muscle weakness. Biochemical tests show abnormally low levels of aryl sulfatase A enzyme in peripheral blood leukocytes and urine. MRI demonstrates symmetrical, confluent areas of high signal on T2W images affecting the periventricular and cerebellar white matter, corpus callosum, and corticospinal tracts with sparing of the subcortical U fibers. The periventricular abnormality shows a striped tigroid pattern. There is no enhancement with administration of intravenous gadolinium. What is the most likely condition? A. Alexander's disease. B. Canavan's disease. C. Acute disseminated encephalomyelitis. D. Mucopolysaccharidosis. E. Metachromatic leukodystrophy. Yusum, 2003, 1928. 32E. Dismyelinating diseases, leukodystrophies, are a wide spectrum of inherited neurodegenerative disorders affecting myelin in the brain and peripheral nerves. Most fall into one of three categories: lysosomal storage diseases, peroxisomal disorders, and diseases caused by mitochondrial dysfunction. The most common, metachromatic leukodystrophy, is an autosomal recessive disorder caused by a deficiency of the lysosomal enzyme aryl sulfatase A, which leads to accumulation of sulfatids in tissues. It usually manifests as a late infantile subtype in children at 18 months of age and is characterized by motor signs of peripheral neuropathy followed by deterioration in intellect, speech, and coordination, leading to death within a few years. On T2W MRI, symmetrical confluent areas of high signal intensity are seen in the periventricular white matter with sparing of the subcortical U fibers. Sparing of the perivascular white matter gives a striped or tigroid appearance to the periventricular area of abnormality, particularly well seen in the centrum semiovale. Other sites often affected are the corpus callosum, internal capsule, and corticospinal tracts. Chione et al., 2002. 33. An elderly male patient presents with signs suggesting acute middle cerebral artery infarction. Around 2 hours after symptom onset, an unenhanced CT of the brain is performed. Among other subtle signs, the basal ganglia are obscured. Reduced perfusion through which of the following vessels best explains the sign? A. Lenticulostriate arteries. B. Anterior choroidal artery. C. Callosomarginal artery. D. Recurrent artery of Hübner. E. Angular artery. Corticospinal tracts. Chione et al. 2002. 33a. The lenticulostriate arteries are vessels arising from the M1 segment of the middle cerebral artery. There are medial and lateral groups. Collectively, they supply the thalamus, caudate, and lentiform nuclei. The callosomarginal artery and the recurrent artery of Hübner are anterior cerebral artery branches. The latter provides some supply to the Module 6, Central Nervous System and A. The lenticulostriate arteries are vessels arising from the M1 segment of the middle cerebral artery. There are medial and lateral groups. Collectively, they supply the thalamus, caudate, and lentiform nuclei. The callosomarginal artery and the recurrent artery of Hübner are anterior cerebral artery branches. The latter provides some supply to the Module 6, Central Nervous System and Head and Neck. Answers. 333. Anterior limb of the internal capsule, and parts of the caudate nucleus and globus pallidus. The angular artery is a cortical branch of the middle cerebral artery. The anterior choroidal artery also supplies parts of the internal capsule and basal ganglia, but is a branch of the internal carotid artery. The nuclei of the basal ganglia are the amygdala, claustrum, lentiform, and caudate nuclei, with the internal, external, and extreme capsules being associated white matter tracts. Butler et al. 19. 1999, 55. C. Loss of gray-white matter. Module 6, Central Nervous System and Head and Neck Questions. 303. 34. An unenhanced CT scan of the brain is performed 3 hours after the onset of signs suggestive of ischemic stroke. Which of the following image window parameters is most likely to reveal the early CT changes? A. Width 400 Hu, center 40 Hu. B. Width 80 Hu, center 20 Hu, center width 8 Hu, center 32 Hu. D. Width 0 Hu, center 0 Hu. E. Width 1500, center 500 Hu. Matter differentiation, obscuration of the lentiform nucleus, and the insular ribbon sign are manifestations of cytotoxic edema that can be seen on CT as early as 2 hours after middle cerebral artery infarction. With normal window settings, with 80 Hu, center 20 Hu, the sensitivity and specificity for acute ischemic stroke detection on unenhanced CT are 57% and 100% respectively. The sensitivity is improved to 71% with window settings of with 8 Hu and center 32 Hu. This setting accentuates the difference between normal and edema to brain tissue. Srinivasan et al. 2006. A 9-month-old boy presents to the pediatric neurologist with general developmental delay, left-sided weakness from birth, and tonic-clonic seizures. MRI performed under anesthetic reveals a thin cleft containing CSF extending from the right lateral ventricle to the cortical surface of the right frontal lobe. The margins of the cleft are opposed and lined with heterotopic gray matter that shows polymicrogyria. Which disorder of cortical formation is described? A. Poencephaly. Poencephaly B, schizencephaly C, holoprosencephaly D, lissencephaly E, hemimegalencephaly. Hemimegalencephaly. 36. A patient is investigated by catheter angiogram for a giant anterior communicating artery aneurysm. Soon after the procedure, the patient experiences excessive nausea. Unenhanced CT of the brain offers no explanation, but a small bright focus is seen in the cerebellum on T2W Mr. images. Which of the following is the most likely explanation? A. Iodinated contrast. Contrast media reaction. B. Rupture of the aneurysm. C. Embolism of vertebral arterial plaque. D. Dissection of internal carotid artery. E. Vasospasm of common carotid artery. Module 6. Central nervous system and head and neck questions. 304. 37. A 39-year-old man known to have HIV, and with clinically deteriorating dementia undergoes MRI of the brain with a provisional diagnosis of HIV encephalopathy. Images show abnormal high signal on T2W and flare images affecting the white matter, caudate nucleus and basal ganglia on a background of brain atrophy. Which additional Mr. characteristic of these lesions is likely to suggest progressive multifocal leukoencephalopathy over HIV encephalopathy? A. Frontal white matter preponderance. B. Clustering around the basal ganglia. C. Involvement of sub. Center 32 Who. This setting accentuates the difference between normal and edema 2 brain tissue. Srinivasan et al. 2006. 35b. The development of the cerebral cortex takes place in 3 stages: cell proliferation, cell migration, and cortical organization. Schizencephaly is a disorder of the final stage, where there is a CSF-containing cleft lined with gray matter, which is often polymicrogyric, connecting the subarachnoid CSF space with the ventricular system. Differentiation can be made from the cyst or cavity of poencephaly by the presence in schizencephaly of a lining of heterotopic gray matter, whereas a porencephalic cyst is lined by white matter. To result in schizencephaly, the insult must involve the entire thickness of the cerebral hemisphere during cortical organization, as in injuries due to prenatal infection, ischemia, or chromosomal abnormalities. Clinical presentation varies but often includes developmental delay, motor impairment, and seizures. C. With 8 Who, center 32 Who. D. With 0 Who, center 0 Who. E. With 1500, center 500 Who. 35. A 9-month-old boy presents to the pediatric neurologist with general developmental delay, left-sided weakness from birth, and tonic-clonic seizures. 35. A 9-month-old boy presents to the pediatric neurologist with general developmental delay, left-sided weakness from birth, and tonic-clonic seizures. MRI performed under anesthetic reveals a thin cleft containing CSF extending from the right lateral ventricle to the cortical surface of the right frontal lobe. The margins of the cleft are opposed and lined with heterotopic gray matter that shows polymicrogyria. Which disorder of cortical formation is described? A. Poencephaly. B. Schizencephaly. C. Holoprosencephaly. D. Lissencephaly. E. Hemimegalencephaly. 36. A patient is investigated by catheter angiogram for a giant anterior communicating artery aneurysm. Soon after the procedure, the patient experiences excessive nausea. Unenhanced CT of the brain offers no explanation, but a small bright focus is seen in the cerebellum on T2W Mr. images. Which of the following is the most likely explanation? A. Iodinated contrast media reaction. B. Rupture of the aneurysm. C. Embolism of vertebral arterial plaque. D. Dissection of internal carotid artery. E. Vasospasm of common carotid artery. Module 6. Central nervous system and head and neck questions. 304. 37. A 39-year-old man known to have HIV, and with clinically deteriorating dementia undergoes MRI of the brain with a PRV. Abdel Razek et al. 2009. 36c. Cerebral catheter angiograms are indicated to investigate an intracranial hemorrhage where aneurysm or arteriovenous malformation is sought, to investigate aneurysms identified on other imaging techniques, to investigate cavernous sinus syndromes, caroticocavernous fistula, and venous sinus thrombosis for preoperative assessment of tumors, and to investigate cerebral ischemia. Idiosyncratic and dose-related renal iodinated contrast reactions are among the complications of cerebral angiography. Groin puncture site complications are also possible, as with any angiogram. Complications specific to cerebral angiography include embolism of plaque, thrombus. Module 6, Central Nervous System and Head and Neck Answers. 334. Sinal diagnosis of HIV encephalopathy. Images show abnormal high signal on T2W and flare images affecting the white matter, caudate nucleus and basal ganglia on a background of brain atrophy. Which additional MR characteristic of these lesions is likely to suggest progressive multifocal leukoencephalopathy over HIV encephalopathy? A. Frontal white matter preponderance. B. Clustering around the basal ganglia. C. Involvement of subcortical U fibers. D. Areas of hemorrhagic necrosis. E. Enhancement with intravenous gadolinium. Or other particulate matter. Catheter-induced spasm or dissection can also occur. Chapman and Nachialny, 2001, 3025. 37c. HIV encephalopathy is a progressive subcortical dementia caused by direct infection of the central nervous system by HIV. It is therefore not an opportunistic infection, and is seen in up to 60% of AIDS cases. The most striking feature is cerebral atrophy and diffuse myelin pallor, manifested as ill-defined, confluent areas of high signal in the white matter on T2W sequences, or low attenuation on CT. Changes are usually bilateral but asymmetrical, with characteristic sparing of the gray matter. Progressive multifocal leukoencephalopathy occurs in only 2–4% of AIDS cases, and is a reactivation of the J.C. John Cunningham virus, resulting in destruction of oligodendrocytes. The most common location is posterior, whereas HIV encephalopathy is more commonly frontal. However, this is an unreliable discriminator. Progressive multifocal leukoencephalopathy characteristically involves the subcortical U fibers and also affects gray matter. It has a very poor prognosis, death occurring within 2–5 months. Balakrishan. 38. Which of the following MR sequences is most sensitive for detecting subcortical and periventricular lesions in multiple sclerosis? A. Axial T1W. B. Axial T2W. C. Axial flare. D. Axial proton density. E. Axial T1W post-gadolinium contrast. 39. A. 6. Balakrishnan et al. 1990. 38c. The flare MR sequence is a heavily T2 weighted inversion recovery sequence designed to nullify the signal from CSF. This highlights any T2 high signal lesions that may be masked on standard T2W images by adjacent high signal of CSF. This is of particular benefit in the periventricular region and corpus callosum, and studies have shown that flare has higher accuracy than intermediate and T2W sequences in the detection of supratentorial cortical, subcortical and periventricular multiple sclerosis lesions. Depending on location, some lesions can be best seen on standard T2W images. These areas include the posterior fossa, brain stem, and spinal cord. Sixty-five-year-old previously well man with a short history of head aches and behavioral change undergoes CT of the brain. This demonstrates an irregular, ill-defined mass in the left frontal lobe extending across the corpus callosum to involve the right frontal lobe. The mass is of low attenuation and contains cystic areas, demonstrates ring enhancement following intravenous contrast, and has considerable surrounding edema. What is the most likely diagnosis? A. Progressive multifocal leukoencephalopathy. B. Glioblastoma multiforme. C. Lymphoma. D. Abscess. E. Metastasis. Cord. Picus et al. 2006. 39. B. Glioblastoma multiforme is the most malignant form of astrocytoma. It occurs in older patients and most commonly affects the deep white matter of the frontal lobes. Classic appearances are of an irregular, ill-defined hypodense mass with necrosis, hemorrhage, and extensive surrounding white matter edema. 90% of cases show enhancement, which may be diffuse, heterogeneous, or ring-like. Tumor spread is directly along white matter tracts and commonly occurs across the corpus callosum to involve both frontal lobes, butterfly glioma. Lymphomas also have a propensity to involve the corpus callosum, but usually are slightly hyperdense due to a high nuclear to cytoplasmic ratio. Metastases may also involve the corpus callosum. Module 6, Central Nervous System and Head and Neck Answers. Module 6, Central Nervous System and Head and Neck Questions. 305. 40. A 35-year-old man is involved in a low-velocity road traffic accident. Within minutes, he experiences an occipital headache and neck pain. On arrival in hospital, he complains of nausea, vertigo, and diplopia. An unenhanced CT scan of the brain is performed. Which of the following abnormal findings is most likely? A. High density seen in CSF of the Sylvian fissure. B. Low density and loss of gray-white matter differentiation in the insular region. C. Expansion of a vertebral artery with a peripheral, high density crescent. D. Lenticular high attenuation between the temporal lobe and temporal bone. E. Crescent-shaped high attenuation between the temporal lobe and temporal bone. 41. A 70-year-old man has severe to cytoplasmic ratio. Metastases may also involve the corpus callosum. Module 6, Central Nervous System and Head and Neck Answers. 335. But tend to be better defined and would be less likely in the absence of a known primary tumor. Progressive multifocal leukoencephalopathy may involve the corpus callosum, but occurs in immunocompromised patients. Involvement of the corpus callosum is not usually a feature of abscesses. Brandt and Helms, 2007, 129-131, Dehnert, 2007, 247-288-9. 40. C. Minor trauma stretching the vertebral artery. Severe rhinorrhea, and then develops a cough with hemoptysis. Vertebral artery over the lateral mass of C2 can cause vertebral artery dissection. Symptoms include headache and neck pain, and as many as 95% of patients develop a stroke after hours to weeks. Imaging will show an axially enlarged vessel with a narrow lumen and a periarterial rim sign. Angiography may demonstrate tapering or occlusion of the artery or the dissection flap. Predisposing factors to spontaneous arterial dissection include fibromuscular dysplasia, Marfan syndrome, collagen vascular disease, and homocystinuria. Dehnert, 2007, 384. Hemoptysis. A chest radiograph shows a large nodule in the right lung, and a subsequent CT thorax demonstrates a cavitary, left lung nodule. A cerebral catheter angiogram, undertaken to investigate a focal motor deficit, is most likely to reveal which of the following. A. A giant Berry aneurysm. B. Multiple aneurysms with stenoses and occlusion. C. Dural arteriovenous malformation. D. Contrast extravasation. E. Numerous collaterals supplying the anterior circle of Willis. (384). 41. B. Nasal and paranasal involvement and migratory lung nodules, which can be cavitary, are typical features of Wegener's granulomatosis. Cerebral vasculitis can also be a feature. MRI findings are nonspecific and include hyperintensities on T2W images, infarcts, and hemorrhage. Angiography may demonstrate occlusion, stenoses, and aneurysms. Weissletter et al. 2007, 525-6. 42. B. Willis. 42. An elderly man undergoes CT for gradual onset of confusion and memory loss. A pattern of generalized global brain atrophy showing marked temporal lobe predominance with an increase in size of the hippocampal choroidal fissure is seen. Coronal T2W images show atrophy of the hippocampus bilaterally. Which condition is most likely to result in such a pattern of volume loss? A. Pick's disease. B. Alzheimer's disease. C. Parkinson's disease. D. Lewy body dementia. E. Multi-infarct dementia. Alzheimer's disease is a progressive neurodegenerative disorder and the most common cause of dementia in elderly people. Current thinking is that imaging can help in the early diagnosis by documenting or quantifying atrophy in certain regions of the brain such as the hippocampus and entorhinal cortex. However, conventional structural imaging has a relatively low sensitivity in Alzheimer's disease and may be normal. Therefore, use is limited to identification of patterns of atrophy and the exclusion of other potential causes of dementia such as normal pressure hydrocephalus, vascular dementia, or space-occupying lesion. Patterns of atrophy, when seen, may be relatively specific for different causes of dementia, with hippocampal atrophy a cardinal radiological sign of Alzheimer's disease. Pick's disease has a frontal and temporal preponderance and is part of the rarer group of diseases under the umbrella term frontotemporal lobe degeneration. Lewy body dementia typically affects the parietal and occipital lobes and the cerebellum, which are usually spared in Alzheimer's disease. Multi-infarct dementia is vascular in origin and will show a patchy distribution. Module 6, Central Nervous System and Head and Neck Answers. 336. 336. Of change. The different patterns of atrophy have also been recently demonstrated with 18-FDG PET. 43. A patient with multiple previous ischemic strokes has an MRI including T2W and DWI sequences. In the left frontal lobe, there is a region of increased T2 signal. The same area is dark on the DWI and bright on the ADC map. Which of the following is the most likely age of this region of ischemia? A. 10 minutes. B. 30 minutes. Center 3 days. D. 2 weeks. E. 4 months. 44. A 62-year-old of change. The different patterns of atrophy have also been recently demonstrated with 18-FDG PET. Petrella et al. 2003. 43. E. The imaging findings are in keeping with a chronic infarct, in which the unrestricted extra water within gliosis gives a high T2 signal, dark DWI, and bright ADC. Cytotoxic edema occurs because of early ischemic damage to the cell membrane Na+/K and ADPase pump. This can be seen as early as 30 minutes after symptom onset as a bright DWI region. T2W images will be normal this early, and the corresponding ADC map dark. DWI signal increases during the first week due to restricted diffusion, but may remain bright for a prolonged period due to T2 shine through. ADC will return to normal at 1-4 weeks, pseudonormalization, when restricted diffusion is matched by increasing amounts of vasogenic edema that is not restricted. Long-term gliosis has extra water that is not restricted. DWI can be usefully thought of as a T2 signal diminished by net water movement. Since the DWI can be bright because of T2 shine through rather than restricted diffusion, comparison of DWI findings with the ADC map is mandatory. Srinivasan et al. 2000. 62-year-old male patient presents with a mass in the right side of his neck. CT shows an enlarged, right-sided lymph node anterior to sternocleidomastoid, below the level of the hyoid bone, and above the cricoid ring. At which level does the node lie? A. Level IB, Level 2C, Level 3D, Level 4E, Level V. 2006. 44. C. Levels 2, 3, and 4 lie anterior to the sternocleidomastoid. Level 2 is from base of skull to hyoid, Level 3 from hyoid to cricoid, and Level 4 from cricoid to clavicle. Level I is the submandibular space. Level V V is posterior to sternocleidomastoid. Weissletter et al. 2007, 627. 45. A 21-year-old presents with back pain, increasing over time. There are no neurological symptoms. A radiograph of the lumbar spine shows a grade 2 spondylolisthesis at L5S1. Which of the following features would suggest the presence of bilateral spondylolysis as the cause? A. Narrowing of AP diameter of spinal canal at L5S1B, widening of AP diameter of spinal canal at L5S1C, lucencies through the laminae of L5D, sclerosis of the pedicles of L5E, reduced height of the L5S1 disc. 46. A 17-year-old boy presents 627-8. 45b. Spondylolysis, pars defect, is seen in 3–7% of the population, with 50% being symptomatic. L5 is the most commonly affected level. There are fractures through the pars interarticularis, which may be unilateral or bilateral. Spondylolisthesis can occur only when pars defects are bilateral. The AP diameter of the canal is widened as the vertebral body and pedicles are detached from the posterior elements and migrate anteriorly. Narrowing of the canal is seen with other causes of spondylolisthesis, particularly degenerative causes. Sclerosis of one pedicle is seen with unilateral pars defects, as the contralateral pedicle undergoes reactive sclerosis due to excessive stress. Dehnert 2007, 224-5. 46d. Presents with headache and is found to have paralysis of upward gaze, Parnot syndrome, on examination. Mr. Scan of the brain identifies an abnormality. What is the most likely site of the lesion? A. Thalamus. B. Occipital lobe. C. Optic chiasm. D. Pineal gland. E. Cerebellar vermis. D. Parnot syndrome, also known as dorsal midbrain syndrome, is characterized by supranuclear paralysis of upward gaze. It results from Module 6, Central Nervous System and Head and Neck. Answers. 337. Injury or compression of the dorsal midbrain, in particular the superior colliculi, and is most commonly seen in young patients with tumors of the pineal gland or midbrain, with pineal germinoma being the most common lesion producing the syndrome. Young women with multiple sclerosis and elderly patients with brainstem stroke may also present with Parnot syndrome. Grossman and Vermis. Module 6, Central Nervous System and Head and Neck questions. 307. 47, a 28-year-old woman presents with a history of headaches and refractory temporal lobe epilepsy. CT of the brain demonstrates a mixed solid cystic, intraparenchymal mass located peripherally in the right temporal lobe, which contains calcification and demonstrates faint enhancement following intravenous contrast. There is minimal surrounding edema. What is the most likely diagnosis? A. Arachnoid cyst. B. Ganglioglioma. With Parnot syndrome. Grossman and Usum, 2003, 156-7. 47. B. Gangliogliomas are low-grade tumors with a good prognosis, generally occurring in patients under the age of 30. Typical presentation is with focal seizures, and ganglioglioma is the most common tumor seen in patients with chronic temporal lobe epilepsy. They are usually well-circumscribed, hypo, or isodense lesions in the temporal lobes. Calcification, 30%, and cyst formation, 0.50%, are common features. There is usually minimal mass effect and surrounding edema. Meningiomas commonly calcify and have minimal surrounding edema, but are extraaxial, and usually demonstrate intense uniform enhancement following intravenous contrast. Decembryoplastic neuroepithelial tumors are commonly associated with partial complex seizures, but usually occur before the age of 20, and characteristically appear as a soap bubble, multicystic lesion, which may remodel the colbrium. Epidermoids and arachnoid cysts are of CSF density, do not enhance with contrast, and are extraaxial lesions. Grossman and Usum, 2003, 136-7, 139. 48D. CT images are displayed with different window. Ganglioglioma. C. Epidermoid. D. Meningioma. E. Decembryoplastic neuroepithelial tumor. 48. Which of the following represents an appropriate window width and level for viewing the bony structures on a CT scan of the brain? A. Width 80, level 35. B. Width 400, level 40. Center width 250, level 70. D. Width 2000, level 500. E. Width 1500, level 500. Window levels and widths to highlight differences in CT attenuation between the structures of interest. Narrow window widths, 8400 Hu, and lower levels, 2080 Hu, are used to emphasize differences between soft tissues, whereas wide widths, 2000 3000 Hu, and higher levels, 300 600 Hu, are used for optimal visualization of bony structures. Images are usually also reconstructed using specific bone algorithms to accentuate the bone-soft tissue interface. Grossman and Usum, 2003, 6-7. 49. B. Longitudinal fractures of the temporal bone represents 49. A 24-year-old male patient presents following a head injury with GCS of 13. There is bruising over the right temporal region. A CT scan shows no intracranial hemorrhage, but does identify a longitudinal fracture through the petrous temporal bone. What complication should be considered? A. Sensorineural hearing loss. B. Conductive hearing loss. C. Vertigo. D. Carotid artery injury. E. Sigmoid sinus injury. %75% of temporal bone fractures and run parallel to the axis of the petrous pyramid. They may cause dislocation of the auditory ossicles, usually the incus, causing a conductive deafness. Sensorineural hearing loss is associated with transverse fractures of the temporal bone, as is vertigo. Facial nerve palsy is seen in both fracture types, but is less common in longitudinal fractures, where it frequently recovers spontaneously. Carotid artery. Module 6, Central Nervous System and Head and Neck answers. 338. And major sinus injuries are not directly associated with petrous temporal fractures. Dehnert, 2007, 208. A 44-year-old man presents with a long history of headaches and more recent onset of seizures. CT of the brain demonstrates an oval, well-defined, heterogeneous, hypodense mass containing large nodular clumps of calcification located peripherally in the right frontal lobe. The mass extends to the cortical margin, and there is erosion of the inner table of the skull. There is minimal surrounding vasogenic edema. What is the most likely diagnosis? Diagnosis. A. Meningioma. B. Oligodendroglioma. C. Astrocytoma. D. Glioblastoma multiforme. E. Ganglioglioma. (2089) 50. B. Oligodendrogliomas are slow-growing tumors, usually presenting in adults aged 30-50 years. They occur most commonly in the frontal lobe and often extend to the cortex, where they may erode the inner table of the skull. Calcification is seen in 70% of cases, typically appearing as large nodular clumps. There is usually a relative absence of surrounding edema. Astrocytomas also usually appear as hypodense calcified lesions with little surrounding edema, but calveol erosion is not usually a feature. Glioblastoma multiforme usually has considerable surrounding edema and rarely calcifies. Gangliogliomas show calcification in a third of cases but tend to occur in children and young adults, and have a predilection for the temporal lobes. Brandt and Helms, 2007, 132-3. 51c. Parathyroid adenomas do not take up protectate, which is accumulated. Ganglioglioma. Module 6, Central Nervous System and Head and Neck questions. 308. 51. A patient presents with colicky, right-sided, abdominal pain, and is found to have multiple renal calculi. Blood tests reveal hypercalcemia and hyperparathyroidism. Ultrasound scan shows a hypoechoic nodule posterior to the left lobe of the thyroid suggestive of parathyroid adenoma, which features on parathyroid scintigraphy using protectate and sestamibi with delayed washout images, would suggest a functioning parathyroid adenoma at this site. A. Increased uptake on protectate and sestamibi studies with delayed washout. B. No uptake on protectate, increased uptake on sestamibi with normal washout. C. No uptake on protectate, increased uptake on sestamibi with delayed washout. D. No uptake on protectate or sestamibi studies including delayed image. E. Increased uptake on protectate, and no uptake on sestamibi study including delayed image. Accumulated by thyroid tissue, whereas sestamibi is taken up by both thyroid and parathyroid tissue. Subtraction of these two images can then be used to show any difference that can be attributed to a parathyroid adenoma. The delayed image typically shows retention of sestamibi in parathyroid adenomas, delayed washout, compared with normal parathyroid and thyroid. Small parathyroid adenomas are often missed by scintigraphy. Smith and Oates, 2004. 52d. Moyamoya disease is 52. A 19-year-old man with axillary freckling has a cerebral angiogram for recurrent hemiparetic episodes. There is bilateral occlusion of the distal internal carotid arteries extending into the proximal anterior and middle cerebral arteries. This is associated with an extensive network of upper brainstem collaterals. Which of the following is the most likely cause of the angiographic findings in this patient? A. Sickle cell disease. B. Atherosclerosis. C. Radiation vasculopathy. D. Moyamoya syndrome. E. Amyloid angiopathy. Is progressive arteritis typically affecting both supraclinoid internal carotid arteries and the anterior two vessels of the circle of Willis, the anterior and middle cerebral arteries? It is termed Moyamoya syndrome when associated with neurofibromatosis, bacterial meningitis, head trauma, tuberculosis, oral contraceptives, atherosclerosis, or sickle cell anemia. Sickle cell anemia and atherosclerosis are not associated with axillary freckling, unlike neurofibromatosis type 1. Amyloid angiopathy should be suspected in elderly normotensive patients with multiple areas of intraaxial hemorrhage sparing the basal ganglia. Dehnert, 2007, 300 53. A 50-year-old female presents with a thunderclap, headache, and fluctuating level of consciousness. Unenhanced CT of the brain shows high-density material layered in the occipital horns of the lateral ventricles. Which of the following is the most appropriate next imaging investigation? A. CT angiography. B. CT venography. C. Mr. angiography. D. Catheter angiography. E. Radionuclide regional cerebral blood flow imaging. 310. 53A. Some 80–90% of subarachnoid hemorrhage is due to aneurysmal rupture. Therefore, when the diagnosis is proven or strongly suspected. Module 6, Central Nervous System and Head and Neck answers. 339. The cerebral arterial circulation requires assessment. 16-slice CT angiography, CTA, is as accurate for aneurysm detection as 2D catheter digital subtraction angiography, DSA. CTA can be used as primary imaging and DSA reserved for difficult cases. It has the advantages of being safe, immediate, swift, and less likely to need sedation or general anesthetic. CTA also offers anatomical information beyond just the cerebral vasculature, in contrast to DSA. With 16-slice CTA, the spatial resolution is similar to DSA, 0.40 mm for CTA, and 0.32 mm in DSA, 2D DSA 33 cm FOV, 1020 for 1020 for matrix, resolution 0.3 to 0.32 mm. When DSA is performed with AP and lateral projections, aneurysms may be masked, but 3D rotational DSA avoids this problem. The CTA parameters are as follows: 0.5 rotation/S with a 10 mm table advance per rotation, and a 5S scan, 16 rows of 0.75 mm reconstructed to 0.4 mm, KVP 120, Ma 130. Tipper et al. 2000. 54, a 20-year-old male is involved in an accident in which one femur is fractured. No other significant injury is revealed by CT of the brain, cervical spine, chest, abdomen, and pelvis. Several hours after the injury, petechial skin hemorrhages appear, associated with respiratory distress and hypoxia. The patient complains of headache shortly before a seizure is witnessed. Repeat CT of the brain is unchanged and looks normal. Which of the following brain MRI findings best accounts for the patient's condition? A. Diffuse low T2 signal in subarachnoid space. B. Crescent-shaped, space-occupying, extraaxial, low T2 signal abnormality. C. Lenticular, space-occupying, extraaxial, low T2 signal abnormality. D. Multiple, small, non-confluent, hyperintense lesions on T2W images and DWI within the cerebral deep white and deep gray matter. E. Multiple, small, non-confluent, hypointense lesions on T2W and DWI within the cerebral deep white and deep gray matter. (2005) 54D. The syndrome described is the fat embolism syndrome. This consists of the triad of acute respiratory distress with hypoxia, petechial skin hemorrhage, and varying degrees of neurological dysfunction. The last includes headache, diminished GCS, seizures, and irritability. Other features are tachycardia, fever, thrombocytopenia, and anemia. It occurs in 0.5–3.5% of long bone fractures. The cause is likely to be the release of bone marrow elements into the circulation as a result of trauma. These act as emboli and they initiate a systemic inflammatory response when free fatty acids are released by the action of pulmonary lipases. The brain lesions seen on MRI are believed to be a combination of these two insults. Microinfarcts result from cerebral fat embolism, and edema results from blood-brain barrier disruption which occurs because of the toxic effect of free fatty acids on brain tissue. Acute extraaxial hemorrhage might explain the neurological features of this case but would not account for the rash or hypoxia. Butte-Riss et al. 2006. And DWI within the cerebral deep white and deep gray matter. E. Multiple, small, non-confluent, hypointense lesions on T2W and DWI within the cerebral deep white and deep gray matter. 55. 1 week following a subarachnoid hemorrhage, a 50-year-old female, who had thus far been making a good recovery, develops intractable vomiting, vertigo, and ataxia. An unenhanced CT of the brain demonstrates unchanged ventricular size, but a new hypodense region in a cerebellar hemisphere. Which of the following complications of subarachnoid hemorrhage is most likely to have occurred? A. Acute obstructive hydrocephalus. B. Delayed communicating hydrocephalus. C. Vasospasm and infarction. D. Transdentorial herniation. E. Rebleed from a berry aneurysm. 56. A 30-year-old female presents with left-sided hearing loss and facial nerve palsy. CT shows a solid mass in the left middle ear behind an intact tympanic membrane, occupying an enlarged attic and eroding the scutum and middle ear ossicles. What is the most likely diagnosis? A. Bell's palsy. B. Cholesteatoma. C. Malignant otitis externa. D. Acoustic neuroma. E. Squamous cell carcinoma. Module 6. Central nervous system and head and neck questions. 55. C. Infarction in this case is cerebellar. Vasospasm is the leading cause of death and morbidity following subarachnoid hemorrhage. It occurs after 72 hours with a peak at 5-17 days. Acute obstructive hydrocephalus results from intraventricular blood, or the resultant ependymitis obstructing the aqueduct of Sylvius, or the outlet of the fourth ventricle. Communicating hydrocephalus usually occurs after 1 week, when the hemorrhage causes impaired CSF absorption. Dehnert, 2007, 327. 56. B. Cholesteatoma is an abnormal collection of .55, 1 week following a subarachnoid hemorrhage, a 50-year-old female, who had thus far been C. Vasospasm and infarction. D. Transtentorial herniation. E. Rebleed from a berry aneurysm. 56. A 30-year-old female presents with left-sided hearing loss and facial nerve palsy. CT shows a solid mass in the left middle ear behind an intact tympanic membrane, occupying an enlarged attic and eroding the scutum and middle ear ossicles. What is the most likely diagnosis? A. Bell's palsy. B. Cholesteatoma. C. Malignant otitis externa. D. Acoustic neuroma. E. Squamous cell carcinoma. Collection of keratinized debris arising from an ingrowth of stratified squamous epithelium and occurs in Module 6. Central nervous system and head and neck answers. 340. Primary, 2%, or acquired, 98% types. The acquired type can be further subdivided, with the most common being a primary, acquired, epidermoid-type lesion of the pars flaccida, located in the attic of the middle ear. Cholesteatomas are benign lesions but cause bone erosion, including the auditory ossicles, resulting in conductive hearing loss. Local extension may compress the geniculate ganglion in the facial canal. 57. A 46-year-old man presents with headaches and visual disturbance and is found to have bitemporal hemianopia on visual field testing. CT of the brain demonstrates a multilobulated, heterogeneous, suprasellar mass containing cystic areas and rim-like calcification. Enhancement of the solid component is observed following intravenous contrast. What is the most likely diagnosis? A. Epidermoid. B. Craniopharyngioma. C. Pituitary macroadenoma. D. Meningioma. E. Rath's cleft cyst. 58. A 20 Fatterpecker et al. 2006. 57b. B. Craniopharyngiomas are the most common suprasellar mass, predominantly occurring in the first and second decades, but with a second peak in the fifth decade. Presenting symptoms include headache secondary to hydrocephalus, bitemporal hemianopia, compression of the optic chiasm, and diabetes insipidus, compression of the pituitary gland. Typical imaging features are calcification, cyst formation, and enhancement that may be solid or nodular. Meningiomas may arise in the suprasellar region and commonly demonstrate calcification, but are generally not cystic. Epidermoids may occasionally demonstrate rim calcification, but rarely enhance following intravenous contrast. Pituitary macroadenomas may undergo hemorrhage, resulting in heterogeneity that can cause confusion with craniopharyngioma, but this typically occurs in adolescence. Calcification in macroadenomas is infrequent. Rax cleft cysts are thin-walled, benign cysts arising in the anterior sellar or suprasellar region. They show no contrast enhancement and rarely calcify. Grossman and 27-year-old he undergoes unenhanced CT of the brain, which demonstrates a well-defined, hyperdense, spherical lesion in the anterosuperior portion of the third ventricle, with asymmetrical enlargement of the lateral ventricles. What is the most likely diagnosis? Yusum, 2003, 541-8. 58b. Colloid cysts arise from the inferior aspect of the septum pellucidum and protrude into the anterior aspect of the third ventricle, where they may cause positional headaches and hydrocephalus due to transient obstruction at the foramen of Monro. They usually contain mucinous fluid, desquamated cells and proteinaceous debris, making them hyperdense on CT. On Mr. Scan, the high protein content, as well as the paramagnetic effect of magnesium, copper and iron in the cyst, results in high signal intensity on T1W and T2W sequences in 60% of cases. Meningiomas and ependymomas may also appear hyperdense, but location within the third ventricle is uncommon for both. Subependymal giant cell astrocytoma is a benign tumor occurring in the region of the foramen of Monro, which may cause obstruction, but it is usually hypodense and is nearly always seen in association with tuberous sclerosis. Choroid plexus papilloma predominantly occurs in children under 5 years of age, and location in the third ventricle is unusual. Dehnert, 2007, 27. A. Meningioma. B. Colloid cyst. C. Ependymoma. D. Subependymal giant cell astrocytoma. E. Choroid plexus papilloma. Papilloma. 59, A 47. Year-old female presents with gradual onset back pain over 4 weeks, with associated pyrexia and tenderness at the thoracolumbar junction. Radiographs show destruction of the end plates at the T12L1 disc level. Which of the following features on further imaging would suggest tuberculous over pyogenic discitis as a cause? A. Single-level involvement. B. Paravertebral soft tissue mass. C. Epidural abscess. D. Disc space loss. E. Calcification. 59. E. Tuberculous discitis tends to occur in children and adults around the age of 50 years. It most commonly affects T12L1, compared with pyogenic discitis, which tends to occur more distally. Tuberculous discitis often affects more than one level contiguously. Paravertebral masses and epidural abscesses are seen as complications in all types of discitis, but calcification within an abscess is virtually diagnostic for tuberculosis. Disc space loss is also seen in all types of discitis, although it tends to be better preserved with tuberculous infection. Burrell et al. 2007. Calcification. 60. Which of the following is the most common radiation-induced CNS tumor? A. Ependymoma. B. Oligodendroglioma. C. Lymphoma. D. Glioblastoma multiforme. E. Meningioma. 2007. 60. E. Meningioma is the most common radiation-induced CNS tumor and has been particularly associated with low-dose radiation treatment for tinea capitis. For the diagnosis of radiation-induced meningioma to be made, the meningioma must arise in the radiation field, appear after a latency period of years, and should not have been the primary tumor irradiated. Radiation-induced meningiomas are more frequently multiple and have higher recurrence rates than non-radiation-induced tumors. Module 6, Central Nervous System and Head and Neck Questions. 311. 61. On an axial section of the brain at the level of the third ventricle, which structure lies immediately lateral to the putamen? A. Internal capsule. B. Globus pallidus. C. External capsule. D. Thalamus. E. Insular cortex. Tumors. Grossman and Yusum, 2003, 1045. 61. C. The lentiform nucleus is composed of a larger lateral component, the putamen, and a smaller medial component, the globus pallidus, separated by a sheet of white matter. The lentiform nucleus is bounded medially by the internal capsule. Lateral to the lentiform nucleus lies the white matter of the external capsule, and then the claustrum, a thin sheet of gray matter. The extreme capsule lies lateral to the claustrum and separates it from the insular cortex. Butler et al. Cortex. 62. Ultrasound examination of the face and neck is performed to instigate a buccal, soft tissue mass that became noticeable during pregnancy. The lesion is heterogeneous and hypoechoic, and has sinusoidal spaces demonstrating slow flow and circular calcifications. Which of the following is the most likely diagnosis? A. Benign lymph node. B. Malignant lymph node. C. Pleomorphic parotid adenoma. D. Arteriovenous malformation. E. Venous vascular malformation. Al. 1999, 41. 62e. Phleboliths, if present, are unique to vascular malformations. Arterial malformations are high flow, while venous, capillary, or combined malformations are low flow. MRI is required to assess the full extent, particularly intraosseous and intracranial, of head and neck vascular malformations. Benign lymph nodes are smooth, elliptical, and hypoechoic with hilar architecture and vascularity. Malignant lymph nodes are typically round, are hypoechoic, have no hilum, and show peripheral vascularity. Malignant lymph nodes with necrosis are seen with squamous cell and papillary cell carcinoma of the thyroid. Internal punctate calcification is seen in metastases from papillary or medullary carcinoma of the thyroid. Connor et al. 2000. A 20-year-old male patient has a MR scan of his spine for investigation of back pain. He has low IQ and multiple skin patches. The MR scan shows bilateral branching tubular paraspinal masses, with widening of the intervertebral foramina and posterior scalloping of the vertebral bodies. A sharply angulated kyphosis is present at the thoracolumbar junction. What is the most likely diagnosis? A. Neurofibromatosis type 1b, neurofibromatosis type 2. C. Tuberous sclerosis. D. Marfan syndrome. E. Ehlers-Danlos syndrome. 342. 63a. Neurofibromatosis type 1, peripheral neurofibromatosis, or von Recklinghausen's disease, is a multisystem disorder affecting the majority of organ systems. The presence of plexiform neurofibroma is pathognomonic. In the spine, there is abnormal development of the vertebral bodies with hypoplasia of pedicles and posterior elements. Dural ectasia is seen secondary to weakness of the meninges. Neurofibromatosis type 2, central neurofibromatosis, is characterized by bilateral acoustic neuromas, meningiomas, and ependymomas. Tuberous sclerosis produces multiple hamartomas and malformations of several organ systems. Marfan's and Ehlers-Danlos syndromes may also cause posterior scalloping of vertebral bodies. Dehnert, 2007, 315-19. 60. Syndrome. 64, a 56-year-old male presents with a mass in the anterior triangle of the neck and is referred for ultrasound scan and biopsy. Ultrasound scan shows a vascular mass splaying the internal and external carotid arteries at their origin. How should cell sampling of the mass be undertaken? A. Perform FNA rather than core biopsy. B. Use multiple passes. C. Use a single pass. D. Ensure that needle midway between internal and external carotid arteries. E. Both FNA and core biopsy contraindicated. Module 6, Central Nerve. 64e. The imaging appearances are highly suggestive of a carotid body tumor, paraganglioma, and biopsy should not be performed, as hemorrhage would be certain due to the high vascularity of the lesion, in addition to the proximity of the carotid system. They present as painless, pulsatile masses in the neck of adults, below the angle of the jaw, and are laterally mobile but vertically fixed. There is splaying of the carotid bifurcation, but preservation of caliber of the two arteries. Contrast imaging shows avid enhancement. Dehnert, 2007. 312. 65. A severely hypoplastic cerebellar vermis in an enlarged bony POS fossa, with associated hydrocephalus and communication of the fourth ventricle with a posterior midline CSF cyst, are features of which of the following posterior fossa malformations? A. Megacisterna magna B, Dandy-Walker malformation C, Dandy-Walker variant D, Arnold-Chiari malformation E, Joubert syndrome. 66. Following a large postpartum hemorrhage, a 25-year 2007, 394. 65b. Classically, the Dandy-Walker malformation consists of partial or total absence of the cerebellar vermis, dilatation of the fourth ventricle into a large cystic mass, an enlarged posterior fossa, hydrocephalus in 75% of cases, and torcular lambdoid inversion, elevation of the torcular urophilia above the lambdoid suture. The proposed etiology is obstruction of CSF outflow at the foramina of Magendie and Luschka. The vermis abnormality is the key component in all forms of the Dandy-Walker complex. The variant is less severe with a better prognosis. Chiari malformations have the fundamental abnormality of an underdeveloped, small posterior fossa, in contrast to the Dandy-Walker complex where it is normal or enlarged. Grossman and Yusum, 2003, 432. 66d. Many of the acute 25-year-old woman develops a severe headache and sudden visual field defect. What is the most likely diagnosis? A. Intracerebral hemorrhage. B. Reversible posterior leukoencephalopathy. C. Subarachnoid hemorrhage. D. Sheehan syndrome. E. Vertebral artery dissection. 67. Which paired vein forms in the Sylvian fissure and travels in the ambient cistern around the midbrain to enter the vein of Galen along with the internal cerebral vein? Neurological conditions of pregnancy occur with rising blood pressure. Sheehan syndrome results from hemorrhage-induced hypotension causing pituitary infarction. Early on, this appears as an enlarged homogeneous pituitary with low T1 signal, high T2 signal, and post-contrast ring enhancement. Later, there is an empty cella. Clinical manifestations include visual field loss, headache, ophthalmoplegia, and pituitary dysfunction, diabetes insipidus. Reversible posterior. Module 6, Central Nerve. Obstruction of CSF outflow at the foramina of Magendie and Luschka. The vermis abnormality is the key component in all forms of the Dandy-Walker complex. The variant is less severe with a better prognosis. Chiari malformations have the fundamental abnormality of an underdeveloped, small posterior fossa, in contrast to the Dandy-Walker complex where it is normal or enlarged. Grossman and Yusum, 2003, 432. 66d. Many of the acute neurological conditions of pregnancy occur with rising blood pressure. Sheehan syndrome results from hemorrhage-induced hypotension causing pituitary infarction. Early on, this appears as an enlarged homogeneous pituitary with low T1 signal, high T2 signal, and post-contrast ring enhancement. Later, there is an empty cella. Clinical manifestations include visual field loss, headache, ophthalmoplegia, and pituitary dysfunction, diabetes insipidus. Reversible posterior. Module 6, Central Nervous System and Head and Neck answers. 343. Leukoencephalopathy produces cortical blindness, headaches, confusion, and seizures. Those affected are often taking immunosuppressant treatment. Imaging features can be identical to eclampsia, peripartum cerebral angiopathy, and hypertensive encephalopathy, but with a posterior predominance. On CT, there is low attenuation change. On MRI, there is high signal on T2W/FLAIR images. ADC maps can differentiate between likely reversible vasogenic edema, high signal on ADC map showing unrestricted diffusion, and cytotoxic edema, low signal due to restricted diffusion, which is more likely to progress to infarct. Microangiopathic hemolytic anemias, such as thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, give widespread ischemia/infarction and hemorrhagic transformation. There is no increased risk in pregnancy of vasculitis, such as systemic lupus erythematosus, Takeusa syndrome, or Moyamoya syndrome. Arteriovenous malformation is no more likely to bleed in pregnancy, but there is an increased risk with arterial aneurysms. Hemorrhage, sepsis, and pulmonary embolism cause hypertension that can cause watershed infarction as well as Sheehan syndrome. Deneen et al. 2000. Vein. A. Superficial middle cerebral or Sylvian vein. B. Basal vein of Rosenthal. C. Vein of Lab. D. Vein of Trillard. E. Thalamus striate vein. Vein. 68. Carotid Doppler. Doppler examination is performed on a patient following a transient ischemic attack. Attack. All other factors are in favor. (2005). 67b. These veins are all part of the supratentorial venous system. The superficial middle cerebral vein forms an arc along the surface of the sylvian fissure and is continuous with the sphenoparietal sinus. The veins of Trillard and Lab are anastomotic veins that connect the superficial middle cerebral vein to the superior sagittal and transverse. Transverse sinuses respectively. The thalamus striate vein is a subependymal vein that passes across the floor of the lateral ventricle, over the thalamus, and into the internal cerebral vein behind the foramen of Monro. The paired internal cerebral veins run along the roof of the third ventricle and enter the vein of Galen with the paired basal veins of Rosenthal. The vein of Galen joins the inferior sagittal sinus and the straight sinus at the venous confluence within the quadrigeminal plate cistern. The straight sinus lies along the junction of the falx and tentorium. The straight sinus, transverse sinus, and superior sagittal sinus meet as the torcular hierophili. Butler et al. 19. Favor of surgical treatment for carotid stenosis. At what peak internal carotid artery velocity would ultrasound scan also support this management? A. 0.50 cm/SB. 75 cm/S. C. 0.100 cm/SD. 200 cm/S. E. 0.250 cm/S. 1999, 57-8. 68E. Carotid ultrasound scan can be used to assess the common, external and internal carotid arteries and the carotid bulb, including the vessel walls and the presence of plaques and stenoses. Doppler scan can display velocity profiles and allow waveform analysis and peak velocity measurement. Flow velocity increases proportionally with the degree of stenosis, except when the affected vessel is almost completely or totally occluded. Here flow velocity drops off. Stenosis above 70% is. Module 6, Central Nervous System and Head and Neck answers. 344. Considered for surgery. This corresponds to a flow rate of greater than 250 cm/s. Weissletter et al. 2007, 508. In the presence of raised intracranial pressure, the anterior cerebral artery is at risk of compression during which of the following types of brain herniation? A. Transforaminal herniation. B. Sphenoid herniation. C. Ascending transtentorial herniation. D. Descending transtentorial herniation. E. Subfalcine herniation. 5089. 69E. Transtentorial herniation may be descending, towards the posterior fossa, or ascending, upward displacement of the cerebellum through the tentorial incisura. Descending transtentorial herniation causes shift of the temporal lobe over the tentorium, which may compress the third cranial nerve, the posterior cerebral and anterior choroidal arteries, and the midbrain. Contralateral hemiparesis may occur due to compression of the ipsilateral cerebral peduncle. Ipsilateral hemiparesis may also occur due to compression of the contralateral cerebral peduncle against the tentorial edge, Kernahan's notch phenomenon, a false localizing sign. Subfalcine herniation occurs when the cingulate gyrus shifts beneath the falx, due to medially directed supratentorial mass effect. This may cause compression of the anterior cerebral artery, resulting in ipsilateral distal anterior cerebral infarction, and internal cerebral veins. Sphenoid herniation involves herniation of the frontal lobe posteriorly across the edge of the sphenoid ridge, and rarely produces significant clinical symptoms. Transforaminal herniation results in herniation of the inferior cerebellum downward through the foramen magnum, which can result in obtundation and death. Dehnert, 2007. Herniation. 70, a 30-year-old man with a history of metastatic malignant melanoma. Melanoma presents with sudden onset of visual loss of the upper right quadrant in both eyes, right superior homonymous quadrantanopia. Emergency CT of the brain demonstrates a hemorrhagic cerebral metastasis with surrounding edema. Which of the following is the most likely location of the lesion? A. Optic chiasm. B. Right temporal lobe. C. Left temporal lobe. D. Left thalamus. E. Right thalamus. (2007) 234. 70. C. The optic radiation runs from the optic chiasm posteriorly to the occipital visual cortex. Each radiation carries with it optical fibers carrying information from the contralateral half of the visual field of each eye. This means a lesion in the left optic radiation will result in loss of vision of the right half of the visual field in both eyes, right homonymous hemianopia. However, as the radiation passes posteriorly from the lateral geniculate nucleus of the thalamus, it divides into two, with one division taking a relatively direct course posteriorly and the other a longer course through the temporal lobe. This is known as Meyer's loop, and the lengthier course means that these fibers are more prone to disruption. The fibers in Meyer's loop carry information from the upper visual field only, so a left temporal lobe lesion that affected Meyer's loop would result in loss of vision only of the upper right quadrants of each eye right superior. Homonymous quadrantanopia. A lesion at the optic chiasm, such as a pituitary macroadenoma, will affect only the fibers that decussate at the chiasm, causing bitemporal loss of vision, bitemporal hemianopia. Thalamus. 71. Sequelae and complications of meningitis that may be identified on contrast-enhanced CT of the brain in the acute phase of the disease include all but which of the following? A. Venous sinus thrombosis. B. Leptomeningeal enhancement. C. Encephalomalacia. D. Ring-enhancing mass lesion. E. Infarction. Hemianopia. Kier et al. 2004. 71. C. Diagnosis of meningitis is made by clinical examination and examination of CSF. Imaging is reserved for complications and to identify. Module 6. Central nervous system and head and neck answers. 345. Contraindications to lumbar puncture. The mechanism of spread is usually hematogenous, common organisms being Neisseria meningitidis, meningococcus, in young adults, Escherichia coli, and Haemophilus influenza. Complications that can be identified on CT include subdural empyema, sterile effusion can be seen with H. influenza, venous sinus thrombosis, infarction, cerebritis, and abscess formation. Leptomeningeal thickening and enhancement may be seen, but its absence does not exclude a diagnosis of uncomplicated meningitis. CT may also identify a potential source of infection such as otitis media, mastoiditis, sinusitis, or orbital cellulitis. 72, A23. Castillo, 2006, 152-4. Old man presents with acute headache. Unenhanced CT of the brain demonstrates a heterogeneous mass at the inferior cerebellar vermis. It is predominantly of fat attenuation with areas of calcification, and does not enhance following administration of intravenous contrast. Multiple droplets of fat attenuation are noted throughout the subarachnoid space. What is the most likely diagnosis? A. Lipoma. B. Arachnoid cyst. C. Dermoid. D. Epidermoid. E. Teratoma. Module 6. Central nervous system and head. C. Epidermoids and dermoids are congenital lesions resulting from inclusion of ectodermal elements during closure of the neural tube. Both have a squamous epithelial lining and produce keratin, but dermoids contain both ectodermal and mesodermal elements, hair follicles, sweat and sebaceous glands, while epidermoids contain only ectodermal elements. Epidermoids are lobulated masses, usually located off the midline, which compress adjacent structures such as cranial nerves, and tend to have appearances on CT and Mr. Skin following that of CSF. Dermoids are usually midline in location and cause symptoms by obstruction of CSF pathways or by rupture and leakage of fat contents, causing chemical meningitis. They have appearances on CT and Mr. Skin following that of fat, and are often heterogeneous with areas of calcification and other soft tissue components. This heterogeneity helps to distinguish a dermoid from a lipoma. Arachnoid cysts are of CSF density but may be distinguished from epidermoids on DWI where they do not show evidence of water restriction. Teratomas are composed of ectodermal, mesodermal, and endodermal elements, and also appear heterogeneous with areas of fat, calcification and cystic components, but these lesions occur most commonly in the pineal and suprasellar regions. Brandt and Helms, 2007, 151-4. (314) 73, between which structures do the dural venous sinuses lie? A. Skull and dura mater. B. Dura mater and dura mater. C. Dura mater and arachnoid mater. D. Arachnoid mater and pia mater. E. Pia mater and brain. 74, A. 60. 73, B. Dural venous sinuses are large venous channels located between the two layers of dura. They also contain arachnoid granulations that are responsible for CSF resorption. Weissletter et al., 2007. 65, old man presents with back stiffness and painful hips. Radiographs of the thoracolumbar spine and pelvis show ossification of the iliolumbar and sacroiliac ligaments with whiskering of the ischial tuberosities. Which of the following additional features is most likely to be seen on the spine radiographs? A. Flowing osteophytes over several vertebral levels. B. Squaring of vertebral bodies. C. Reduced disc spaces. D. Sclerosis of vertebral bodies. E. Posterior longitudinal ligament calcification. (2007, 507). 74, A. The pelvic features are suggestive of diffuse idiopathic skeletal hyperostosis, DISH. Flowing anterior vertebral osteophytes, especially in the lower thoracic region, are very suggestive of this condition, and Module 6, Central Nervous System and Head and Neck answers. 346. Disc spaces are usually well preserved. Vertebral body squaring is seen in a number of conditions, including ankylosing spondylitis but not DISH. Holler et al., 1989. 75, E. Hemorrhage occurs in 5–10% of tumors. Features suggesting tumor rather than benign hemorrhage include complex CT pattern, incomplete hemosiderin ring, persisting edema, or mass on follow-up studies, and multiple lesions. Weissletter et al., 2007, 512. 76, C. 75, which of the following imaging features of an intraparenchymal hemorrhage is most likely to suggest that the hemorrhage originates from an underlying tumor? A. Homogeneous CT appearance. B. Complete hemosiderin ring. C. Complete resolution on follow-up imaging. D. Solitary hemorrhage. E. Post-contrast enhancement of non-hemorrhagic areas. (76) Bilateral globus pallidus injury manifest radiologically as high signal on T2W Mr. sequences is indicative of poisoning by which of the following substances? A. Lead. B. Methanol. C. Carbon monoxide. D. Carbon dioxide. E. Mercury. Module. Carbon monoxide poisoning results in irreversible formation of carboxyhemoglobin. Carboxyhemoglobin in the blood, causing anoxic ischemic encephalopathy. These changes are usually bilateral and affect the basal ganglia, most commonly the globus pallidus. Injury is demonstrated as high signal on T2W and FLAIR images, and shows restricted diffusion on DWI. Areas less commonly affected acutely are the putamen, which is characteristically involved in methanol poisoning, and caudate nucleus. Involvement elsewhere can occur but is less common than basal ganglia changes. Delayed post-anoxic encephalopathy may develop several weeks after carbon monoxide poisoning, and MRI then shows further high T2 signal changes in the corpus callosum, subcortical fibers, and internal and external capsules, with low T2 signal changes in the thalamus and putamen. O'Donnell et al., 2000. 77, D. Both ameloblastoma and radicular 77. A 31-year-old woman presents with a painless mass involving the right side of the mandible. Radiographs show a well-defined, lucid lesion. Which of the cysts most commonly present in the 3rd to 5th decades of life as a painless lump, often as an The following additional findings favor a diagnosis of ameloblastoma over a radicular cyst. A. Absence of matrix mineralization. B. Location at the symphysis menti. C. Location at the root of a tooth. D. Soap bubble appearance. E. Rim of cortical bone. 78. The fourth branch of the external carotid artery crosses the inferior border of the mandible before traversing the cheek, and forms an important connection between the external and internal carotid arteries by anastomosing with branches of the ophthalmic artery. Which artery is described? A. Ascending pharyngeal. B. Lingual. C. Facial. D. Maxillary. E. Superficial temporal. 79. A hypertensive, 75-year-old female admitted with an acute stroke is found on unenhanced CT of the brain to have an acute basal ganglia hemorrhage. If an MRI were performed 2 weeks later, what signal characteristics would the region of hemorrhage return? A. Isointense on T1W images and hyperintense on T2W images. B. Butler et al. 1999, 116-17. 79. B. The MRI signal of blood depends first on whether it is moving or static, since on most sequences movement produces a signal void. When it is static, the signal returned by blood reflects the magnetic properties of the blood products and their location. Hyperacute hemorrhage is intracellular oxyhemoglobin that is diamagnetic, returning an isointense T1 and bright T2 signal. At 1-2 days, deoxygenation has occurred, making the iron paramagnetic. It remains intracellular and returns an isointense T1 signal, and is dark on T2W images. At 2-7 days, hemorrhage contains paramagnetic intracellular methemoglobin. This is bright on T1W images and dark on T2W images. The methemoglobin becomes extracellular from 1 week to 4 weeks, and the MRI signal is bright on both T1W and T2W sequences. Chronic hemorrhage contains hemosiderin/ferritin, which is ferromagnetic, is dark on T1W images, and has a dark rim on T2W sequences. Sequences. Weiss letter E. What signal characteristics would the region of hemorrhage return? A. Isointense on T1W images. 80. A 24-year-old man is an unrestrained passenger in a car involved in a high-speed collision. He is found unconscious at the scene. CT of the brain is normal. Mr. Scan of the brain demonstrates multiple small foci of high signal on T2W images in the white matter of the parasagittal regions of the frontal lobes and the paraventricular regions of the temporal lobes. What is the most likely diagnosis? A. Acute subdural hematoma. B. Diffuse axonal injury. C. Cortical contusions. D. Intracerebral hematoma. E. Subcortical gray matter injury. A 31-year-old woman presents to the neurologist with a transient episode of facial numbness. On close questioning, she reveals a transient episode of blurred vision which occurred several months previously. MRI, including Mr. Angiography, shows several small areas of low signal on T1W and high signal on T2W images in the optic nerves and cerebellar peduncles. The flare sequence demonstrates further multiple, ovoid, high signal areas in the corpus callosum and periventricular white matter. The angiogram demonstrates normal head and neck vessels. These imaging findings support which of the following diagnoses? A. Internal carotid artery dissection. B. Multiple sclerosis. C. Progressive multifocal leukoencephalopathy. D. Acute disseminated encephalomyelitis. E. Wallerian degeneration. D. Acute disseminated encephalomyelitis. E. Wallerian degeneration. 82. In normal anatomy of the nasal cavity, which structure opens into the inferior meatus below the inferior nasal turbinate? A. Anterior ethmoidal ostium. B. Posterior ethmoidal ostium. C. Frontal sinus ostium. D. Maxillary sinus ostium. E. Nasolacrimal duct. Commonly hemorrhagic. Subcortical gray matter injury. B. MRI is an important clinical tool to support the clinical diagnosis of multiple sclerosis. Multiple sclerosis is an inflammatory autoimmune disease of the brain and spine characterized by demyelination and Module 6, Central Nervous System and Head and Neck. Answers. 348. Damage to axons. It typically presents in a relapsing and remitting way with symptoms dependent on the location of lesions. MR enables identification of areas of tissue injury and disease progression and location of active lesions. The lesions are high signal on T2W sequences, including flare, and can be found throughout the brain, but have a predilection for periventricular white matter, appearing perpendicular to the ventricles with an ovoid conformation, Dawson's fingers. The corpus callosum and cranial nerves are also common sites, and the flare sequence helps to reveal lesions that would otherwise be masked by the high T2 signal of CSF. The corpus callosum is best examined on sagittal sequences. On T1W sequences, lesions are often isointense, but low signal can indicate areas of severe inflammation, so-called black holes, resulting in disease progression and disability. Enhancement with intravenous gadolinium is sometimes seen in lesions during the acute inflammatory phase and is thought to be the earliest detectable sign on MRI. GE. Duct. 83. Regional cerebral blood flow imaging. Imaging is required to localize an epileptic focus. Of the following radiopharmaceuticals, which is the most appropriate for this purpose? GE 2006. 82E. The lateral nasal wall is separated into superior, middle, and inferior meatises by three curled bony shells called turbinates or conchae. The nasolacrimal duct opens into the anterior aspect of the inferior meatus, and is usually the only opening seen there. The other ostia all open into the middle meatus, with the exceptions of the posterior ethmoidal ostia, superior meatus, and sphenoidal ostia, posterior to the superior turbinate in the sphenoethmoidal recess. The sphenopalatine foramen lies inferior to the sphenoethmoidal recess, posterior to the middle turbinate. Dehnert 2007, 367. 83E. Conventional radionuclide brain scans are not indicated when CT or MRI can be used. Brain accumulation of radiotracer occurs at sites of blood-brain barrier disruption and increased vascularity such as cerebrometastases, meningioma, and high-grade glioma. Reagents used are 99 MTC, labeled protectate, 99 MTC, labeled DTPA, and when it was available, 99 MTC, labeled glucoheptanate. Radionuclide imaging is also able to provide regional blood flow mapping, which is used to localize epileptic foci, map cerebrovascular disease, investigate dementia, assess treatments, and confirm brain death. 99 MTC, labeled Hembao, is the most used radiopharmaceutical overall. It is lipophilic and therefore crosses the blood-brain barrier, and in doing so is distributed in proportion to cerebral blood flow. 99 MTC, labeled ECD, is another regional blood flow imaging tracer, and can therefore also be used in the localization of epileptic foci. 18 FDG PET tracers are distributed through the brain according to metabolic activity. Chapman and Nachialny, 2001, 2. C. 99 MTC, labeled Protecnitate D. On T1W images. T2W images reveal concordant asymmetrical but bilateral areas of high signal in the anterior temporal lobes, insular cortices, and hippocampi. There is no enhancement following administration of intravenous gadolinium. What is the most likely condition? A. Lymphoma. Lymphoma B. HIV encephalitis. C. Cytomegalovirus encephalitis D. Herpes simplex encephalitis E. 84 D. Herpes simplex virus is the most common cause of fatal endemic encephalitis, often leaving survivors with severe memory and personality problems. Both oral, type 1, and genital, type 2, strains may produce encephalitis with a multimodal distribution, affecting neonates, due to cross-infection with type 2 from the mother during birth, children and adults. Childhood and adult infection is caused by the type 1 virus and results in fulminant necrotizing encephalitis presenting with acute confusion and deteriorating rapidly to coma. Focal neurological deficits are seen in only 30% of cases. The virus asymmetrically affects the temporal lobes, insula, orbitofrontal region, and cingulate gyrus, causing edema. This is seen as high signal on T2W/FLAIR images, with DWI appearances variable depending on the presence of infarction. The putamen is characteristically spared, and the areas of encephalitis typically do not show enhancement on CT or MRI. Grossman and Yusum, 2003, 28892. A young patient presents with double vision, and is found on examination to have ptosis and dilated left pupil. The gaze in the same eye is fixed inferiorly and laterally, and when the ipsilateral light reflex is tested, there is constriction of the contralateral pupil only. CT shows a small spontaneous brainstem hemorrhage thought to be due to an arteriovenous malformation. Which of the following locations of the hemorrhage best explains the presenting symptoms? A. Superior pons B. Inferior pons. C. Superior midbrain D. Inferior midbrain E. Superior medulla. Grossman and Yusum, 2003, 28892. 85 C. The signs describe oculomotor nerve palsy. This will result in a characteristic down and out position of the affected eye due to the unantagonized action of the superior oblique and lateral rectus muscles, which are supplied by the trochlear and abducent nerves respectively. The palsy will also cause ptosis and pupillary dilatation due to loss of the motor component of the light reflex. The nuclei of the oculomotor nerves are found in the superior midbrain within the tegmentum, at the level of the superior colliculi. Those of the trochlear nerve are situated at the level of the inferior colliculi. The oculomotor nerve arises from the anterior surface of the midbrain on the medial side of the cerebral peduncle, passing between the posterior cerebral and superior cerebellar arteries to enter the cavernous sinus and pass into the orbit via the superior orbital fissure. Butler et al., 1999, 37. A 27-year-old female presents with emotional lability and headaches. MRI of the brain demonstrates a well-defined mass in the pericallosal region. The mass is hyperintense on T1W images and demonstrates no enhancement with intravenous gadolinium. There is associated agenesis of the corpus callosum. What is the most likely diagnosis? A. Dermoid B. Lipoma. C. Intrahemispheric arachnoid cyst D. Epidermoid E. Lymphoma. 86 B. Intracranial lipomas appear as well-circumscribed masses of fat density on CT with occasional rim calcification. On Mr. Scan, characteristic appearances are of hyperintensity on T1W images, with chemical shift artifact or signal suppression on fat-saturated sequences. Approximately 30% of intracranial lipomas occur in the pericallosal region, and there is a high incidence of associated congenital anomalies, most commonly agenesis of the corpus callosum, but also encephalocele and cutaneous frontal lipomas. Intrahemispheric arachnoid cysts may occur in association with agenesis of the corpus callosum, but they are of CSF density and, like epidermoids, appear hypointense on T1W images. Dermoids have signal characteristics following those of fat, but are usually more heterogeneous and not associated with callosal. Module 6, Central Nervous System and Head and Neck Answers. 350. Anomalies. Lymphoma may involve the corpus callosum, but appears ISO or hypointense on T1W images. Grossman and Yusum, 2000. Anomalies. D. Epidermoid E. Lymphoma. 87. A 38-year-old male presents with a history of recent head injury and unilateral, painful, pulsatile exophthalmos with reduced visual acuity. CT shows swelling of the extraocular muscles with dilation of the superior ophthalmic vein and cavernous sinus on the ipsilateral side, both of which enhance avidly. What is the most likely diagnosis? A. Ophthalmic varix. B. Arteriovenous malformation. C. Lymphangioma. D. Carotid. 87. D. Carotid cavernous sinus fistula may occur spontaneously, secondary to aneurysm rupture, dural sinus thrombosis, or atherosclerosis, or after trauma/surgery. It presents with a classic triad of pulsatile exophthalmos, conjunctival chemosis, and auscultatory brute. However, reduction in visual acuity may be the only sign. Secondary findings such as proptosis, congestive extraocular muscle enlargement, and distension with enhancement of the superior ophthalmic vein and cavernous sinus are usually identified on routine CT or MRI. However, catheter angiography is usually required for lesion classification and treatment planning prior to embolization. Drainage may also occur into the contralateral cavernous sinus, resulting in dilatation and enhancement. Ophthalmic varices present with intermittent exophthalmos related to straining, with dilatation of superior and/or inferior ophthalmic veins, which may thrombose. Orbital pseudotumor is an idiopathic inflammatory condition affecting all orbital contents but vascular. Dilatation is not a feature. Smoker et al. 2008. A 30-year-old female with a past medical history of spontaneous pulmonary embolus presents 2 weeks after giving birth with severe headache, vomiting, and drowsiness. Unenhanced CT of the brain shows areas of low attenuation with sulcal effacement and small areas of parenchymal hemorrhage. These changes do not conform to an arterial distribution. What is the most likely finding on the post-contrast CT brain? A. Ring enhancement of the low attenuation regions. B. Demonstration of a basilar tip aneurysm. C. Empty delta sign. D. Anterior pituitary enlargement. E. Vertebral artery dissection flap. 88. C. The patient has a venous sinus thrombosis causing congestion and venous infarction. Veno-occlusive disease is commoner in the first 3 weeks postpartum, especially if there is underlying hypercoagulability, including factor V Leiden abnormality, antiphospholipid antibody syndrome, and protein C, protein S or antithrombin 3 deficiency. On unenhanced CT, there may be hyperdense veins, gray-white matter junction hemorrhage, and brain edema. On CT venography, an empty delta can be seen because thrombus rather than iodinated contrast occupies the affected dural venous sinus. Deneen et al. 89. Which of the following structures lies in the parapharyngeal space? A. Internal carotid artery. B. Hypoglossal nerve. C. Maxillary artery. D. Lingual tonsil. E. Vagus nerve. 89. C. The parapharyngeal space is triangular shaped and extends from the skull base to the hyoid. It contains fat, branches of the mandibular division of the trigeminal nerve, maxillary artery, ascending pharyngeal artery, and pharyngeal venous plexus. The internal carotid artery, vagus nerve, and hypoglossal nerve lie in the carotid space. The lingual tonsils lie in the pharyngeal mucosal space. Butler et al. 1999, 100. A 43-year-old female presents on an ultrasound list for a thyroid FNA. She has an enlarging thyroid gland, right lobe more so than the left, and is biochemically euthyroid. Ultrasound scan shows multiple solid nodules with some cystic areas and foci of calcification throughout both lobes and the isthmus, with no obvious dominant nodule. Regarding FNA, how should the radiologist proceed? A. Target solid lesion. B. Target calcification. C. Use multiple passes in both lobes. D. Use single pass at multiple sites. E. Do not perform FNA. 90. E. The appearances are characteristic of a multinodular goiter, and FNA can be misleading in these cases. Imaging diagnosis alone is usually sufficient. If there is a dominant nodule that is clearly larger than the others or solitary enlarging nodule found on follow-up, then FNA should be performed to exclude malignancy. Kim et al. 2000. E. Do not perform FNA. 91. A 31-year-old woman attends neurology clinic with a history of orthostatic headache, worst on standing, which sometimes induces vomiting, and relieved by lying down. MRI of the brain and cervical spine shows crowding of the foramen magnum due to low-lying cerebellar tonsils, elongation of the fourth ventricle, effacement of the prepontine cistern, and a prominent pituitary gland. In the spine, an extradural fluid signal collection is identified ventral to the cord. Administration of intravenous gadolinium reveals smooth areas of intracranial pachymeningeal enhancement. Which of the following diagnoses is best supported by these findings? A. Intracranial hypotension. B. Intracranial hypertension. C. Migraine. D. Chiari eye malformation. E. Dandy-Walker malformation. Kim et al. 2008. 91. A. Spontaneous intracranial hypotension is a syndrome of low CSF pressure characterized by postural headaches in patients without any history of dural puncture or penetrating trauma. It is thought to arise from an occult CSF leak due to dural defects reducing CSF volume and subsequently pressure. Intracranial findings include downward displacement of the brain, subdural effusions, engorgement of other venous structures, including the hyperemic pituitary, and low-lying cerebellar tonsils. There may be flattening of the pons as the brain sags against the skull base. Diffuse pachymeningeal enhancement is due to increased venous supply in an attempt to maintain intracranial volume and therefore pressure, according to the Monroe-Kelly doctrine. In the spine, extradural fluid collection is indicative of an occult leak. Treatment is with an epidural blood patch where autologous blood is introduced into the extradural epidural space in an attempt to seal the microscopic dural defects. Shivink et al. 2008. A 40-year-old male presents with pain in the jaw associated with dental caries. An orthopantomogram demonstrates a lytic lesion of 1 centimeter in diameter, associated with the apex of a carious tooth. The lesion has a thin rim of cortical bone, and there is some resorption of the root. What is the likely diagnosis? A. Ameloblastoma. B. Odontogenic keratosis. C. Dentigerous cyst. D. Radicular cyst. E. Odontoma. 90. Shivink et al. 2008. 92d. A radicular cyst is the commonest type of cyst in the jaw and is associated with the apex of a tooth. It may displace teeth and cause mild root resorption. Ameloblastoma, adamantinoma of the jaw, odontogenic keratocyst, and dentigerous cyst are all associated with the crown of a tooth, usually unerupted, and can be difficult to distinguish from each other on imaging alone. They are all odontogenic with no mineralization and may be large and expand the mandible. Odontomas are the commonest odontogenic mass, 67%, and show mineralization. They are seen in 10-20-year-olds presenting with single or multiple tooth-like masses. Dehnert, 2007, 1-8. A 14-year-old boy is hit by a vehicle while riding his bike and sustains a left-sided head injury. Paramedics report a transient loss of consciousness at the scene. On examination, he is confused with a GCS of 13/15. Unenhanced CT of the brain is performed, which shows a biconvex extraaxial collection in the left temporoparietal region with attenuation value of 65 Hu. On bone windows, there is an undisplaced, linear, left temporoparietal skull fracture. What is the most likely diagnosis? A. Acute subdural hematoma. B. Acute extradural hematoma. C. Acute subarachnoid hemorrhage. D. Acute intracerebral hematoma. E. Cerebral cortex. Dehnert, 2007, 182. 93b. Acute extradural hematomas are traumatic in origin and tend to be commoner in younger patients. 2/3 of cases involve the temporoparietal region, and 75-95% of patients have an associated skull fracture. Bleeding is usually from the underlying middle meningeal artery, though it may also be due to disruption of the middle meningeal vein, dural venous sinuses, or diploic veins. Typical appearances are of a high-density lentiform or biconvex collection, which forms between the Module 6, Central Nervous System and Head and Neck. Answers. 352. Inner table of the skull and the dura mater. The dura is firmly bound to the skull at sutural margins, so extradural hematomas tend not to cross suture lines. Acute subdural hematomas usually follow severe trauma and have a poorer prognosis than acute extradural hematomas due to a high incidence of associated contusions and other brain injuries. They tend to be crescentic in shape and may freely extend across suture lines, being limited only by the interhemispheric fissure and tentorium. They are commonly bilateral, particularly in infants, and have no particular association with skull fractures. Dehnert, 2007, 2. Cortical contusion. 94. The WADA test is performed before surgical treatment for medically refractory epilepsy. It involves intraarterial injections of sodium amobarbital with 99 mTC, labeled HMAO, followed by SPECT imaging to map the distribution of the barbiturate. What is the main indication for this test? A. Chemical ablation of epileptic foci. B. Localization of speech and memory centers. C. Mapping symmetry of brain vascular distribution. D. Identification of interhemispheric collateral circulation. E. 286-7. 94. B. SPECTOF. The central nervous system allows assessment of the collateral circulation during balloon occlusion, mapping the extent and distribution of vasospasm associated with subarachnoid hemorrhage, evaluation of cerebrovascular reserve prior to carotid endarterectomy, identification of seizure foci, and guiding of stereotactic brain biopsy and tumor recurrence. The WADA test is used to predict the probability of memory and speech complications in patients before they undergo anterior temporal lobectomy with amygdalohippocamectomy, a surgical treatment for medically refractory epilepsy. The test involves injection of radiopharmaceutical and short-acting barbiturate, usually sodium amobarbital, into each of the carotid arteries in turn. Loss of memory or speech following one of the injections indicates that these centers lie in the ipsilateral temporal lobe. The results of the WADA test can be negated by vessels crossing the midline and the presence of such. E. Evaluation of cerebrovascular reserve. 95. A 64-year-old man with squamous cell carcinoma of the lung presents with difficulty in speaking. On examination, he is noted to have dysarthric speech and deviation of the tongue to the left. CT of the brain is unremarkable, but review on bone windows reveals a destructive lesion of the left side of the skull base consistent with a bony metastasis. Which of the following skull base structures is most likely to be involved? A. Foramen ovale. B. Foramen rotundum. C. Foramen lacerum. D. Jugular foramen. E. Hypoglossal canal. Berger et al. 1996. 95. E. Hypoglossal nerve, cranial nerve 12, palsy is uncommon, characteristically producing unilateral atrophy of the tongue musculature, and resulting in deviation of the tongue towards the weak side and dysarthric speech. Supranuclear lesions cause contralateral paralysis, tongue deviation away from the side of the lesion, whereas nuclear and infranuclear lesions cause ipsilateral paralysis, tongue deviation towards the side of the lesion. The hypoglossal nerve exits the skull base via the hypoglossal canal, and this segment of the nerve may be affected by benign or malignant tumors and trauma of the skull base. Metastatic tumors most commonly arise from the lung, breast, or prostate primaries. Direct extension from nasopharyngeal squamous cell carcinoma may also produce skull base erosion involving the hypoglossal canal. Other pathological conditions that can affect the nerve at this site include skull base infections, Paget's disease, and fibrous dysplasia. Thompson and Smoker. 96. A 65-year-old man has an unenhanced CT of the brain for recent onset, unilateral hand weakness. The CT shows multiple, bilateral, small supratentorial regions of low attenuation. Which of the following is the most likely associated finding? A. Unilateral carotid atherosclerosis. B. Cardiac valve disease. C. Coarctation of proximal descending thoracic aorta. D. Subclavian stenosis. E. Sinus tachycardia. 96. B. Thromboembolic cerebral infarction occurs in atrial fibrillation, cardiac valve disease, fibromuscular dysplasia, intracranial aneurysms, sickle cell disease, atherosclerosis, and thrombotic thrombocytopenic purpura. Multiple infarcts are more likely with extracranial disease, and can take the form of a shower of emboli. In these cases, the distribution is typically bilateral and more commonly supratentorial. Dehnert, 2007. 97. In brain imaging performed to characterize a chronic subdural collection, which feature is more likely to favor a diagnosis of subdural empyema over sterile effusion? A. Isointense Mr. signal on T1W images. B. Hyperintense Mr. signal on T2W images. C. Subfalcine herniation. D. Restricted diffusion on Mr. DWI. E. Low attenuation on CT. Dehnert, 2007, 233. 97. D. Abscess cavities and empyemas are homogeneously hyperintense on Mr. DWI and low on ADC map due to the increased viscosity of the purulent material that they contain, resulting in restricted diffusion of water. Sterile effusions are hypointense on DWI and have an ADC appearance similar to that of CSF due to their lower viscosity and free macrodiffusion of water. Diffusion images can therefore be important when deciding whether to intervene surgically or conservatively manage subdural collections, as empyema requires timely surgical drainage. Contrast enhancement of the wall of the collection may be seen on CT and MRI, but its absence does not exclude the diagnosis of a purulent collection. Collection. Likewise, one may expect to see additional mass effect with an infected collection, but this too is not sensitive enough to exclude infection by its absence. Schaefer et al. 2000. E. Low attenuation on CT. 98. A 50-year-old female presents with increasing weakness of the lower limbs and sensory disturbance. MRI shows an extramedullary, intradural ovoid mass in the mid-thoracic region. The lesion has signal isointense to the cord on T1W and T2W images, and enhances avidly with intravenous gadolinium. What is the most likely diagnosis? A. Meningioma. B. Nerve sheath tumor. C. Ependymoma. D. Dermoid. E. A. Meningiomas in the spine are seen mainly in females, 80%, and in those over 40 years of age. They have similar signal characteristics to the cord on MRI and enhance avidly. They can cause symptoms related to cord compression. Bone erosion is seen in 10%. Nerve sheath tumors produce fusiform masses arising from the nerve roots, often extending through the intervertebral foramen, causing them to be dumbbell-shaped. They are isointense to muscle on T1W and hyperintense to fat on T2W images. Ependymomas are usually located in the phylum terminale and show low/intermediate signal on T1W images, with foci of high signal on T2W images, and they often enhance. Dermoids usually occur in the conus or cauda equina and are associated with spinal dysraphism in 1/3 of cases. They are variable in signal on T1W but are high signal on T2W images. Dehnert, 2007, 216-17. E. Arachnoid cyst. 99. A 21-year-old man presents with acute headache. He undergoes CT of the brain, which demonstrates a well-circumscribed, lobulated, partially cystic, calcified mass in the frontal horn of the left lateral ventricle, attached to the septum pellucidum. There is acute blood seen layering in the left lateral ventricle and mild hydrocephalus. What is the most likely diagnosis? A. Choroid plexus papilloma. B. Colloid cyst. C. Intraventricular oligodendroglioma. D. Central neurocytoma. E. Subependymoma. Module 6. Central nervous system and head and neck questions. 99. D. Central neurocytomas, also known as intraventricular neurocytomas, are benign tumors of the lateral and third ventricles usually presenting in adults aged 20-40 years. They frequently calcify, 69%, and contain cystic spaces. Attachment to the septum pellucidum is a characteristic feature. Lesions appear isointense to gray matter on all Mr. sequences. Module 6. Central nervous system and head and neck answers. 354. and show mild to moderate contrast enhancement. Central neurocytomas were previously frequently mistaken for intraventricular oligodendrogliomas, which have very similar imaging features but are actually quite rare. In addition, neurocytomas undergo hemorrhage into the tumor or ventricle more frequently, helping to distinguish the two. Colloid cysts arise within the third ventricle and rarely calcify. Calcify. Subependymomas may arise in the lateral ventricles with an attachment to the septum pellucidum, and cyst formation and calcification may be seen in large tumors. However, most occur in patients over 40 years of age. Choroid plexus papillomas generally occur in children under 5 years of age. Brandt and Helms, 2007, 143-5. 100A. Opsoclonus myoclonus syndrome is characterized by opsoclonus in combination with myoclonus. 321. 100. A 2-year-old boy presents with involuntary psychotic eye movements, opsoclonus, and myoclonus of the trunk and limbs. What are the most likely findings on MRI of the brain? A. Normal appearances. B. Cystic lesion in the posterior fossa with enhancing neural nodule. C. Cerebellar atrophy. D. Central symmetrical lesions in the pons of high signal intensity on T2W images. E. Caudally displaced brain stem and fourth ventricle with tonsillar herniation. Myoclonus of the trunk, limbs or head. It may be idiopathic or occur as a paraneoplastic syndrome, when it may follow a relapsing remitting course. In adults, it is most commonly associated with breast and squamous cell lung carcinoma, while in children it is associated with neuroblastoma. The syndrome usually precedes diagnosis of the underlying malignancy, and in children should prompt investigation to identify an underlying neuroblastoma. MIBG whole body scintigraphy may be helpful in identifying occult disease if conventional imaging is negative. Mr. Scan of the brain is usually normal. Rutherford et al., 2007.